Hi, my name is Neil Nathan, and today we're going to be talking about evaluating and treating mold toxicity with the use of mycotoxin assays. This presentation is going to be in two parts, each about an hour long. So first, part one, and we're going to talk primarily in part one about the evaluation process. Part two will be a detailed evaluation of treatment. So let's begin. So first of all, I have no financial ties to any laboratory, medication, or supplement that I'm going to be discussing in this presentation. The science of the diagnosis and treatment of mold toxicity is currently in its infancy. This presentation is an attempt to synthesize current information and approaches, but keep in mind that this is a work in progress, and there's going to be inevitable changes to our knowledge as we move along. So first of all, I want to share with you a bias in my presentation, which is that my experience evolved medically so that more and more complicated, difficult, sensitive patients began to be referred to me by my colleagues, so that as my practice evolved, I worked with an unusually sensitive, toxic group of patients, and I'm gearing my lecture to that population. Now, many patients who present to you can be treated much more aggressively, but if you can treat the sensitive patient, the rest will be a lot more straightforward. Okay, so why do we want to study mold toxicity? It's estimated by many experts that as many as 10 million Americans currently have some degree of mold toxicity. It's an epidemic. It's an epidemic far greater than AIDS ever was, but it's just beginning to be appreciated. To what extent? So if you are working with a patient with chronic inflammatory illness or any chronic symptoms that are complicated, if you fail to consider the possibility of mold toxicity, there's a strong possibility that you will treat something else, such as Lyme or co-infections, when actually those are not the problem or not the main problem. The persistent inflammation, which is triggered by environmental toxins and infections, has now been linked to many of the most common illnesses that we are asked to treat on a daily basis. These are some of the most difficult that we have to treat because of their complexity. So we're talking about things that have really become epidemic and common, like chronic fatigue syndrome, fibromyalgia, Lyme disease with its co-infections, mold toxicity, PANS, PANDAS, autism spectrum disorders, and neurodegenerative diseases. Common things that we see, all of which have increased astronomically in our population in the last 20 years. Now, mold toxicity triggers other conditions which profoundly influence your patient's presentation and illness. And these include mast cell activation, which is present in at least 70% of the patients that I see with mold toxicity. Secondary porphyrias, methylation dysfunction is almost universal. Reactivation of viral, bacterial, and parasitic infections. And super important, limbic dysfunction and vagal nerve dysfunction, which again profoundly influence the presentation. And I always want to point out that, as many of you are probably discovering, if you don't know much about mold toxicity or Lyme disease, as many of our colleagues do not. So when the diagnosis is missed or wrong, patients do not feel heard or validated. They're told it's all in your head. Their families have become less supportive and understanding because their physicians are doubting their perceptions. Now, our patients know that they are sick, but they're not being honored for that. And that adds enormously to the illness itself. Here's a nice review paper, originally written in 2004, one of the first papers which you can check at your leisure. Okay, so given the complexity of patients that we're seeing with chronic inflammatory illness, The old medical models no longer work. The concept of having a strep throat, having a culture for it, finding that it's strep, treating it with penicillin, great model for acute illness. For chronic illness, we need new models. The cell danger response is probably the most profound of those models. Dr. Richard Horowitz has a 16-point differential diagnostic map. Dr. Dale Bredesen has a 36-point recode program for Alzheimer's. And then we have Dr. Shoemaker's biotoxin pathway. All of these new models share a perspective on how to understand this complexity. And I encourage you all to study these models so that you can understand and put in perspective better what you're looking at. So today, I'm going to focus on mold toxicity, its presentation, how to clarify the diagnosis, and then in part 2, how to approach treatment in a step-by-step program. Now, each patient is genetically and biochemically unique, so each will require their own approach. A rigid algorithm will not work, and that's not what I'm going to give you. But I'm going to give you an overview, a perspective, so that you'll be able to help these patients greatly. Okay, let's talk about mold. We use the word mold kind of loosely. So mold includes more than mold itself, including the fungi and the mycotoxins made by those fungi. But other components of mold toxicity include actinomycetes, volatile organic compounds, and a number of proteinish materials which have irritating effect on the body, such as beta-glucans, hemolysins, mannans, and proteinases. So when we talk about mold, all of those things are an inflammatory soup, but the ones that are the easiest to measure and to measure our efficacy of treatment are mycotoxins, and that will be the focus of what we talk about. Now, for years, we primarily in medicine thought about mold in terms of allergy. That mold causes an allergic reaction, well known, and allergists have worked with this greatly over the years. We also know that mold can cause a systemic infection, which is serious and life-threatening and requires intravenous treatment. But that's not what we're talking about here. What we're talking about here is colonization of mold of the sinuses or the gastrointestinal tract, producing toxins. And it's really the toxins that we're going to be talking about today. Our understanding of toxins and our knowledge about toxins is really somewhat rudimentary because it's only recently been appreciated how profoundly important that is in causing illness. So in a very nice review paper written by Jeanette Hoke, 2013, which I encourage you all to look at, she reminds us that symptoms and illness due to mold exposure result from varying mechanisms, including infection, toxicity, allergy, irritant effects, and systemic inflammation. Individual responses to exposure vary depending on genetic makeup, severity, and duration of exposure. Underlying nutritional status is important, and it's also important to understand that the health consequences of exposure to water-damaged environments likely result from a combination of factors acting synergistically. Well, I'm speaking to you now from my office in Northern California. It's currently raining, and I live literally right next to a redwood forest. In front of me in this redwood forest are probably 1,000 species of mold, the vast majority of which are not toxic. So, are all molds toxic? No, but these are. Stachybotrys, which people call black mold. Keep in mind that other mold species like Aspergillus nigrus can do it as well. Penicillium, Aspergillus, Chaetomium, Alternaria, Fusarium, and Wallemia are the most common that we are exposed to that cause illness. So, as I was saying, we're exposed to hundreds of mold out of doors. Now that can affect allergy, but in general, each mold species right outside my window here carves out its own ecological niche so that each mold species makes toxins to keep other molds out of their ecological niche. So we've got separate mold species that grow on rhododendron, azalea, redwood, tan oak, etc. So that's not the problem. I can walk in my forest and not get mold toxic and not be worried about it. However, when mold grows inside water-damaged buildings called sick building syndrome, that's where we get into trouble. So the inflammation that mold toxins trigger involve both innate immunity, and here we have Dr. Shoemaker's biotoxin pathway, clarifying how mold toxin stimulates the immune system to make inflammatory cytokines and doesn't know how to turn it off. So it keeps making inflammatory cytokines until we figure out how to help the body. In addition, we have acquired immunity, which is mold allergy. And many of our patients have mold allergy and mold toxicity, which is a nasty combination. Okay, so as we start, I'd like you to keep these mold effects in mind. Mold affects the immune system profoundly, making patients much more prone to opportunistic infections and Lyme disease, viral infections. Mold toxicity affects the limbic system and the vagal nerve system profoundly, so that the vast majority of people who develop multiple chemical sensitivity and other sensitivities are triggered by mold. It also causes what we call electromagnetic dysthymia or electromagnetic sensitivity, so that we're seeing a marked increase in EMF sensitivity now, of which mold is a major player. It also triggers food allergies, and virtually every type of autoimmune condition has been linked to mold toxicity. So here's the bottom line. Mold makes everything else worse. Okay, so what do we look for in mold toxicity? And I'm going to present this information in two different tiers, if you will. First, I'm going to give you an overview of the mold symptoms. Then I want to focus on the ones that are quite unique to mold, what I would call pathognomonic or key symptoms that will really allow you to immediately go, you have that symptom. I really better think about mold. So, overview. Fatigue, weakness, is common in most patients. Muscle aches, cramps, unusual pains, which some people call ice pick or lightning bolt, headaches, sensitivity to bright light, tearing, blurred vision, chronic sinus congestion, cough, chest pain, shortness of breath, abdominal pain, diarrhea, what looks like IBS, joint pain, tendinitis, morning stiffness, cognitive impairment is super common, difficulties with recent memory, assimilation of new information, word finding, handling numbers, confusion, sustaining concentration, disorientation, and what people call brain fog. Skin sensitivity to touch, mood swings, appetite swings, sweating, especially at night, temperature dysregulation, numbness, tingling, vertigo, metallic taste in the mouth, excessive thirst, frequent urination, impotence, menorrhagia, nausea, vomiting. Okay, so systemically, virtually any symptom you can think of could be linked to mold toxicity, and not everybody has every symptom. Based on genetics or biochemistry, certain patients will have some symptoms, but not others. Again, as I promised, some are more than others. So I call these the miss me symptoms, meaning if you miss them, you're going to wish you hadn't. So first of all, medical conditions that look like named diagnoses, but are actually mold toxicity. Fibromyalgia and chronic fatigue syndrome, often mold toxicity. Later, we'll talk about a paper written by Dr. Brewer in 2013, in which he took 112 patients with chronic fatigue syndrome and measured their urine mycotoxins and found that 92% of them had mold toxins in their urine, and when treated, the vast majority of them got well. So fibromyalgia is often thought to have no cause, as is chronic fatigue, but for many patients, it's mold toxicity. Anytime you get a label by a specialist of atypical rheumatoid arthritis, atypical MS, Alzheimer's disease, Parkinson's disease, when the specialist is aware that it looks kind of like that illness, but doesn't fit the way they're comfortable with, whenever you hear the word atypical, think mold toxicity. Asthma and chronic sinusitis are often misdiagnosed when they're really mold toxicity. A whole realm of psychiatric disorders are actually mold toxicity, especially if they come up later in life with no history of anxiety or depression before. So anxiety, especially unrelated to stressors, depression, depersonalization and derealization, cognitive impairment, mood swings, obsessive compulsive disorder, whenever those come up and have not been present before, consider the possibility of mold toxicity. Unique symptoms. If a patient describes their pain or discomfort as being electrical in nature, think mold. Ice pick pains, think mold. Paresthesias, especially if they're in a non-dermatomal distribution. What I mean by that is they're not just in the toes or hands, or they can be, but if they're on the face or in the center of the chest or the back or the middle of the abdomen, neurologists will say, oh, those are psychological paresthesias. Not psychological. They're caused by the effect of mold toxin on the sympathetic nervous system. If a patient complains of an unusual internal vibration or tremor, they can't see it, but they feel it. It's quite disturbing, actually quite scary to many patients. This is either mold or Bartonella. And an increased sensitivity to everything: light, sound, touch, chemicals, food, EMF. Anyone with an increased sensitivity, think mold toxicity. So I hope that this overview will get you thinking about your patients, maybe some that you haven't figured out, and going, I wonder if that's mold toxicity. It's way more common than you realize. Okay, so when you're exposed to mold, often people are aware that the mold is making them sick and they move or they leave or they take a vacation. Sometimes they get better, often they don't. That's because they've colonized and the mold is living in them. But why do some people have trouble getting rid of mold and some don't? It's estimated that about 25% of people are genetically more susceptible to mold than the rest of the population. So it's actually quite common in a household for one person to be having symptoms and other members of the household do not. And so the obvious immediate assumption is, oh, it's got to be in your head. This is psychogenic. I'm fine. I don't know why you're sick. We're both exposed to the same thing. Not true. If you're genetically predisposed, you may stay toxic. So part of the difficulty here is that for genetically susceptible individuals, without the ability to make antibodies to directly clear toxin, the only mechanism those patients have to eliminating the offending toxin is to use the organic anion transport system in the small bile ducts of the liver, which secretes the toxin into bile, bottom line. So the body processes toxins, all toxins, mold toxin, in the liver. It's transported to the bile, where the bile binds to it. The bile then flows into the upper intestine, following the short stay in the gallbladder. But the toxins don't stay in the intestine. The body has what's called the enterohepatic circulation system, in which in the small intestine, the body treasures bile So it reabsorbs it, still attached to toxin, and brings it back to the gallbladder and back to the liver. So it recirculates and doesn't leave the body. So these patients stay toxic. Let's get started with a simple case presentation. This is one of my early ones. I first started working on this with Dr. Shoemaker in 2005. And this particular 31-year-old woman, when I was practicing in Missouri, I originally saw her in March of 2006, early patient, and there's a reason for that. Her symptoms began at work 3 years earlier when she was exposed to mold in a building that had a very leaky roof. Now, unfortunately, this occurred in close proximity to a traumatic abortion that occurred in a difficult divorce. And the reason that's important is that her symptoms were so widespread and hard to understand that her physicians all assumed that the abortion and the difficult divorce had caused her problems. But in point of fact, it was something else. In August of 2005, she found extensive mold in her home, which had to be remediated. About that time, she developed violent daily emesis, throwing up, which lasted for months. Extensive workup by specialists gave her the diagnoses of bipolar disorder, IBS, and hypochondriasis. Since her exposure, she gained 35 pounds and developed multiple chemical sensitivities, persistent nausea and vomiting, headaches. She couldn't think clearly, poor decision-making. She said, quote, "It's like I'm inept." Visual blurring, bouts of chest tightness and bronchospasm. This constellation of symptoms couldn't be put together by her physicians, none of whom knew anything about mold toxicity. She had recently lost her job of 14 years, trying to raise 3 children by herself as a single parent, could barely function. Her energy level was rated 2 out of 10. She couldn't sleep well, woke unrefreshed, scattered joint pains across her neck, shoulders, and back. You could see how she might be diagnosed with fibromyalgia or chronic fatigue at this point. A visual contrast test, which was one of the few tests we had back then, was positive, and I'll go over that with you a little bit later. She had a low DHEA, suggesting that her adrenal gland was involved, and also low progesterone. So we started on a little bit of progesterone, and we started on the only binder I knew about at the time, which was cholestyramine, 1 scoop 3 times a day. 6 weeks later, after starting treatment, she was 80% better, mentally better, energy markedly improved, despite the fact that she was staying in her moldy home. She was able to get a new job and be able to work, but she noticed that when she missed a single dose of her cholestyramine, she became lethargic, like she used to be. Interestingly, she offered a copy of Dr. Shoemaker's book, Mold Warriors, to her physician, who had not made the diagnosis, but her physician refused to even look at the book. So, now that we have a handle of mold toxicity and what it is, we first have to understand what it's doing to the body so that we can repair that damage. We've got to remove the toxin from the body, and then we have to remove exposure to mold in the patient's environment. Now, mold, it is treatable. That's my take-home message. Always be aware. We can treat mold toxicity, and the vast majority of my patients get well. But it is complicated. We're going to go over the complications in detail. So actually, what is a toxin? What is biotoxicity or neurotoxicity? It all stems from what are called ionophores, which is the name of a particular type of a molecule. So toxins with similar structures and weight activate particular receptors. The toxins consist of an inner water-loving or hydrophilic component of the molecule, surrounded by a fat-loving or lipophilic group. Because it has a lipophilic and hydrophilic group, it can pass readily at will through any membrane, through any system in the body. Because it's a small molecule, and the innermost part is identical to that of a water molecule, this allows it to easily diffuse across membranes, moving from cell to cell without even needing to enter the bloodstream. So this makes these type of toxins particularly nasty. There's a wide range of microbial toxins, of which mold is one. Chlamydia, mycoplasma, some viruses, Lyme disease and some of the co-infections such as Bartonella and Babesia, Pfiesteria, which is an outbreak of certain algae in certain water systems, Ciguatera, which is a type of toxicity you can get from eating fish from tropical waters like red snapper, barracuda, or grouper, brown recluse spider bites, and other blue-green algae infestations in Florida like Cylindrospermopsis are all examples of toxins that you might run into. So just a quick understanding of how do we get here and why do we know so little about it? First of all, mycotoxins have been known since biblical times. There are references to it in Leviticus, which are very clear. But again, although mold allergy was known, the concept of mold toxicity only recently started to percolate into our consciousness medically. In the 1990s, there were scattered reports. The Department of Defense did research into mold toxicity in the 70s and 80s, which is why we know how certain binders work, because it was considered to be used for biological warfare, especially against us, so we had to know something about it. We started to get some inkling of mold toxin back in 1999, when the Mayo Clinic discovered that what they had been calling chronic bacterial sinusitis, which was not responding to antibiotics, was actually fungal sinusitis and responded to taking amphotericin B intranasally. 2003, Michael Gray and his group put out several publications beginning to lay out this complicated list of symptoms, which I've given you, was related to mold toxicity and could be treated. Here's some of their articles, and also a list of Dr. Shoemaker's book, Mold Warriors, which came out in 2005, which really put a lot of this information together so we could begin to understand what it was and what we were looking at. So I rarely like complicated slides, and I'm only going to briefly show this to you and suggest you look at it on your own. This is Dr. Shoemaker's biotoxin pathway, which began to put all of this information on the map. On the left, you can see how biotoxin, just like mold toxin, enters the cell. It binds to the surface toll receptor on a fat cell, and that sets off nuclear changes which affect the leptin receptor, VIP and AVP in the brain, produces a reduction of melanocyte-stimulating hormone, which does all of these things that you're seeing here. It affects sleep, pain, gastrointestinal systems, the ability to deal with stress, the immune system, infections. It affects hormones like ADH, adrenal, thyroid, and sex hormones, and profoundly affects the immune system, causing a cytokine persistence that causes a persistent inflammation that doesn't stop until we get rid of the cause. So I'm not going to belabor this, but this lays out for us all the things that mold toxin can do to us and helps us understand all of the systems that are affected. So central to diagnosis is a careful history and physical exam, listening for the clues that we outlined in the symptoms. Now they're so varied and they fluctuate and they may overlap several other conditions. So making a good diagnosis is critical. Dr. Shoemaker developed this system, most of which I no longer use, and we'll get into more detail later, which includes measuring a variety of biochemical parameters like MSH, VIP, TGF-beta1, C4a, MMP9, and others. It also includes doing a visual contrast test measuring something called markons, which we'll talk about, measuring hormones and clotting factors to get a feel for what the mold is doing to the body. Okay, and here, if you get those parameters, this is what Dr. Shoemaker views as normal. Dr. Shoemaker developed a measurement of the HLA-DR genetics that he felt linked patients to mold toxicity, Lyme disease, other chemical sensitivities, and he laid out certain genetic pieces that he called dreaded genetic, which included the 4353 and others. In my own experience, I've measured hundreds of these HLA-DRs, and I have not seen correlation between the results and how patients respond to treatment. So in other words, I don't find this a helpful test. In fact, it scares patients if they had the, quote, dreaded genes, if they're reading Dr. Shoemaker's materials, and they scares them in such a way that they often feel that they can't get well because they're genetically not predisposed. I really discourage getting patients into that because there's not that correlation. The vast majority of physicians that I work with who are mold experts have come to the same conclusion that I have. So I bring it up because you may have heard about it or read about it. So again, I encourage you not to measure that and not to scare your patients by information that will not affect their therapeutic outcome. So in the beginning, the only test we really had to hint that someone had mold toxicity was what is called visual contrast sensitivity, also called functional acuity contrast. It's a very simple, non-invasive test, which I'll show you next, that developed by Ken Hudnell at the Environmental Protection Agency and was used for screening and monitoring of some of these conditions. I'm sorry that this is a slightly blurry slide, but what the visual contrast consists of is a simple aluminum frame with a V shape at one end, which goes into the chin, and you simply hold this card in front of you. And the card has black and white alternating lines in different configurations that fade out as you go across the card and get narrower and narrower as you go down the card. What you can do is literally score how well someone can see these lines. And looking at some of the numbers in detail, we can literally see literally a pass or fail score for visual contrast. So this is actually a study, which I'll show you on the next slide, by Dr. Shoemaker, in which on the bottom line, you can see the scores of people who had mold toxicity, who then took cholestyramine, abbreviated CSM, and you can see that come up to non-cases, meaning people who did not have mold toxicity, and you can see complete normalization of the visual contrast when cholestyramine was given to those patients. Okay, this is the paper from which this comes. Now, I do want to emphasize that the visual contrast test was very helpful to us in the beginning, and I still do it, but it's not specific for mold toxicity. It will be abnormal in mold toxin, also in Lyme disease, and also in mercury toxicity, and perhaps several other conditions. Okay, so once you suspect mold toxicity, what's next? Hey, we've got a good history here. We have a symptom profile that fits it. So how do we confirm the diagnosis? And let me say here, there's three basic components to treating mold toxicity, which we'll get more into in our next lecture. First, you have to evaluate the patient's environment to be sure they're not living or working in a moldy environment. You can't get well. Say it again. You cannot get well if you continue to live with exposure to mold. Can't happen. It's absolutely critical. So one of the first steps is to test the home for mold. There's several ways of doing that. One of the things I like to start with is mold plates. They're crude, but really helpful in helping you pinpoint if there is a problem and where to look in more detail. Now, mold plates are simply Petri dishes that have a media on them that grow mold. You simply take the Petri dish, open the top, put it on the floor of whatever room you're testing, leave it exposed to air for 2 hours, put the top of the plate back on, and see what grows. If something is growing, send it in for analysis, and then we have a good idea of what's going on. A bit more accurate is ERMI testing, in which you vacuum up some dust from the rooms that you're looking at, and you use PCR technology to look at 36 different toxic mold species in more detail. If there's any question, you want independent environmental evaluation. Now, remediation may be really expensive and may not work. So one of the things that is the most difficult about treating patients with mold toxicity is whether they have the resources to leave the home, to be safe, and get treated. So on this and the next few slides are a point system developed by Dr. Shoemaker for evaluating a Hertzmeet, an ERMI report. Specific points are given for specific fungal species. So a score of over 15 is considered too dangerous to live in. The score of 11 to 15 is borderline and should be evaluated. And any score under 11 is viewed as being probably safe. Okay, the most important and easy way to make the diagnosis, from my perspective, is urine mycotoxin testing. Okay. Why should we start there? First of all, urine mycotoxins are far more specific in making the diagnosis than the biochemical markers that I alluded to before. Those markers will give you information that is not specific to mold. A wide variety of inflammatory materials will affect those markers. So if they're abnormal, we know we have a problem, but we don't know that it's mold. Excuse me. So markers suggest the presence of an inflammatory illness, but again, they don't tell us about the cause. A urine test confirms the diagnosis as mold toxicity, keeping in mind that there may be other things going on. A positive urine test tells us precisely which toxins are involved, so we can be precise as to which binders will be clinically helpful. And that will become extremely relevant in our next presentation when we talk about how to use binders specifically to bind toxins specifically. Here's a paper which began the process of looking at these. This is the original, another paper which talks about measuring mycotoxins in patients who have chronic rhinosinusitis, which I alluded to as a main colonization site. This is the original paper that I alluded to at the Mayo Clinic, showing that 96% of surgical nasal cultures were positive with the presence of eosinophils prominent, and actually showed that it was mold toxicity and not bacterial, which is what people had assumed for many, many years. There are two main types of testing currently available for mycotoxins. The ELISA testing is available through real-time, and liquid chromatography mass spec is available from Great Plains and Vibrant Health. The differences between them. Now, mass spec is theoretically more accurate and reproducible, but it's really specific as to what is being measured. ELISA testing measures the toxins and their metabolites. It's semi-quantitative, but it actually can give us more information than mass spec sometimes. So they're different. Real-time measures these toxins, and Great Plains measures these. They're not exactly the same. There's a bit of an overlap, but you'll often see marked differences in the reports. The question I get a lot is, which test is better? They don't measure the same things in the same way, so comparison is not possible. in clinical practice, both give me very important information. So I measure both. Now, cost may be a consideration. Over the last few years, I have personally found that the real-time test is more consistent and more comprehensive. So if I have to pick one, it would be from the real-time laboratory. But that is my bias. I would also say that a lot of the physicians that I teach have come to the same conclusion. Okay, so if you're going to do a urine test, it helps to do what we call a provocation or challenge testing. When we first started doing this, we realized that some patients who very clearly had mold toxicity had a negative test the first time out. This is really important to understand. And we found that if we had them do a sauna or a hot bath the night before, and if we had them take glutathione for several days to a week previously, both of which improve the body's ability to mobilize toxins and get it into the urine, we got much more accurate results, and we got very few false negatives. So we began to move to doing this fairly routinely, but I'm going to talk about that in more detail. So the preferred way of doing this test would be to use 500 milligrams of glutathione twice a day for a week, collecting urine on the seventh day after doing something to sweat, like a sauna, a hot bath, or a hot tub the night before, and that way I get the most accurate readings. If you're going to do a repeat test, it's important to stop the binders for 3 days before you collect it so you get an accurate reading. Otherwise, you're going to get a false low reading. Now, here's a big caveat. Be careful with the provocation process. Remember, I said that most of my patients are really sensitive. Many of them are unable to take glutathione without having a severe reaction to it. It does indeed mobilize toxin, but faster than they can process it, and it makes them more toxic and worse, and sometimes profoundly and quickly. So if a patient is very sensitive, be careful about how much glutathione you give it, and some patients can't take it at all. So if they can't, that's okay. We can still get the urine test. But it's really important to be aware of that, or you're going to have patients mad at you for the provocation process. I also tell them, if you have a reaction, collect your urine right then. Do not continue to take it for the rest of the week. And if you do that, you're going to have much less difficulty. Again, I need to emphasize this. Anything that mobilizes mold toxin may inadvertently pull more toxin into the body than it's capable of dealing with. This may lead to an exacerbation, which may be severe, of mold toxicity. If this happens with the glutathione, and can also happen with a sauna, stop it and collect your urine immediately. I believe that was worth repeating. Any positive test, even if it is, quote, indeterminate, meaning borderline, is likely to be significant. This is very important. The initial testing numbers may not reflect the total toxic load. That is because many of our patients have a compromised ability to detoxify, and they can barely, even with a challenge, get the toxin out of their body into the urine. So that your first test is often what I call tip of the iceberg, meaning it does not reflect the true burden, but it also reflects the compromised ability to detoxify. And so both of those factors need to be considered here. Okay, so we have to align the testing with the clinical picture. A question I get a lot is, people look at their numbers and yes, they have mold toxicity, but they want to know, how toxic am I? You can't really tell that from your testing, especially your first test, because it's measuring both the ability to detoxify and what's in that body. The vast majority of patients, to the tune of about 80%, will have a higher number on the second test, because as they get better, their ability to detoxify will improve, and their numbers will go up. That does not mean they're worse. It actually means they're better. Let me go over that in a little more detail. So on repeat testing, high results may mean, under 2 there, improved detoxification, which is quite common. However, it may also mean that the patient is being re-exposed to mold. If they are taking a binder or taking an antifungal, binding, if done to excess, can mobilize toxin faster than they can process it and get them worse. And I'll show you an example of that in just a minute. Or if you're taking an antifungal, you can release more toxin into the body and those numbers will go up. Yet another mechanism which needs to be understood is molds don't make mycotoxins willy-nilly. It's very energy draining on the mold cell to make it. They make it in response to a threat. Now, taking antifungals is a threat. So when patients take antifungals, this stimulates mold to make more toxin. And we often see this mechanism come into play at the end of treatment. And here's a paper that demonstrates what I just told you, proving that does indeed happen. Okay, so let's give a case example of this. Had a 60-year-old patient who had had long-standing Lyme disease, who had improved quite a lot. However, the fact that she hadn't really gotten well stimulated me at some point to test her for mold. This is in my early days of working. So on her initial mold test, she showed a high trichothecene. So I asked her to take binders for trichothecene, which are primarily, as we'll teach you, clay, charcoal, and chlorella. Now I told her to start very slowly and gently and slowly increase, but she was really proactive. She took her binders in large doses, increasing the doses rapidly, and she got much worse with severe exacerbation of her joint pain, cognition, and fatigue. So let me show you her test. Can't see this that well, but this is her original test showing her trichothecene at 1.21. And at the time, the upper limit of normal was 0.18, meaning this is 6 times the upper level of normal. Okay. Then she took her binders, had no other interventions. So now she has a toxic level of ochratoxin, which hadn't shown up before. Now she has a toxic level of aflatoxin, and the trichothecenes have shot up to 4.43 from 1.21. This is just taking binders, meaning the binders have mobilized mold toxin faster than she could get rid of it or process it, and she got much worse. So her treatment was simple. We stopped her binders, and within a couple of weeks, she was much better. So how do we distinguish an increase of toxicity from improved detoxification? So if a patient is getting worse steadily, which we don't see with improved detoxification, we stopped her binders for several weeks, her exacerbation resolved, we got the doses of binders right, she improved steadily, and she got well. Now, one of the arguments which many people have heard is, well, doesn't everyone have mycotoxins in their urine? Okay, so we did a study. Oh, I'm sorry, I did not do that study, but I reviewed it. Great Plains did a study a couple of years ago in which they took 82 controls and 103 mold patients. Now, interestingly, 51% of the controls did have a small amount of ochratoxin. And there you could legitimately say, well, everyone's got some mycotoxin in their urine. Here's the biggie. Those controls averaged only 1.6, a very, very tiny amount. Now, the ochratoxins, which were present in 85% of the mold patients, their levels averaged greater than 18. So it was pretty easy to distinguish which patients were toxic and which weren't from the level. And no other toxin measure did this. So every other toxin was not present in controls, so that it's not true that everyone has mycotoxins in their urine. And if you have a tiny amount of ochratoxin, uh, typically it's not enough to even show up on the test. What does a negative test mean? Okay, so number one, okay, maybe your patient doesn't have mold toxicity. Okay. Number two, the patient's ability to detoxify is so compromised they can't excrete toxin in the urine. And if you suspect it, treat them empirically. Number three, the test isn't measuring the toxin causing the symptoms. For example, no lab currently measures Wallemia, which is a significant mold toxin, but won't show up on our testing. So you can be mold toxic and it won't show up. And number four, occasionally we see inaccurate tests, and I've seen them from both labs. So although some of my patients complain that the mycotoxin testing is somewhat expensive, it's absolutely critical for establishing not only the diagnosis, but then I know which mold species are present, and I know how to treat that with precision. Now, keep in mind, treatment is usually a year or more. Occasionally, you will have a patient who will respond quickly and get well. I have seen them, but that is rare. It's really important you tell your patients from the get-go, this is going to take time. So treatment is expensive. You want to be sure you're treating the right thing. It's well worth the cost to get the test. Okay, another case study. We have here a 40-year-old male who had successfully treated Lyme disease, but was still struggling with fatigue, mild cognitive issues, but had recently reported an intense increase in neck, shoulder, and joint pain. The real-time test, which I'll show you, showed elevated trichothecene. He improved a little with binders and with nasal and oral treatment, which we'll go over, but the pain remained debilitating. Now, this was at the time when gliotoxin first appeared on the real-time tests as being available. So we repeated his test, and his gliotoxin came back at 5.42. At that time, the upper level of normal was 0.2. So we're looking at 25 times the upper level of normal, okay? So gliotoxin is treated a little differently than trichothecene. Doesn't respond to exactly the same binders. Gliotoxin responds to clay and Saccharomyces boulardii and NAC, N-acetylcysteine. So when we realized that we had another toxin that we had to deal with, we treated him for that. So we added more to his regimen. Keep in mind that we believe that gliotoxin is made not only by Aspergillus, but also by Candida. So it's a strong indication that treating Candida is very relevant. So we also added oral nystatin. After 3 or 4 months, which is fairly short in most mold treatment, he reported marked reduction of his pain. And by April of that year, his pain was 80 to 85% better. His cognition and fatigue much less, and his gliotoxin was now negative. Of particular interest in this case is a treatment that we'll talk about in our next presentation, low-dose immunotherapy, LDI. He was particularly interested in trying LDI, and we created a unique antigen for him by taking a washing of his nasal secretions and making the LDI from that. That was a unique component to his treatment program and may be why he responded faster than most people do. And this is his follow-up, of which his gliotoxin there, can't see it well, but it's literally negative. You can see that all of his toxin levels are now not present, and his clinical response is excellent. So what we've done is to give you an overview of mold toxicity, I hope a reasonably detailed understanding of how it presents, what symptoms to look at, and what symptoms are so important that the mere mention of them should make you think mold toxicity. We've gone over some of the conditions that you should be thinking about about mold toxicity being part of it. We've gone over how to diagnose it. And in our next presentation, what we're going to talk about in a lot more detail is how to treat it and how to look at the other aspects of conditions that mold toxicity triggers that really require attention. So thank you very much for listening to this presentation, and we'll be back with part 2 in just a bit.